facial aesthetic practice. So the first talk will be by Dr. Rwituja Thomas, who is practicing in Delhi. Over to you, Rwituja.
Very good morning to everyone. I thank Dr. Sahil for including me in his talk. So what I'll be covering first is the facial aging and basic anatomy. Under these categories, I will also be including some of the danger zones, which would have also been part of Sahil's talk, but I'll try to cover some of the parts of filler in this as well. So the basic features of aging include bone loss, that is the structural change, fat loss, which leads to volume loss, superficial lines and wrinkles, and overall drooping and descent of the face. Now, progressively, the bone keeps remodeling with age, and areas resorb in a very predictable manner. So, in this, you can see that the mandibular angle, it sort of becomes more and more obtuse with age. So, if we know exactly how the angle would have been earlier, even if you don't have any older pictures, you can plan treatment accordingly. Similarly, with respect to the bone resorption around the orbit, which is more important from the point of view of the oculofacial surgeon, it occurs mainly in the inferolateral and superomedial regions. So these are the areas which primarily need augmentation. Now coming to the perioral area, there is with aging, the skin envelope sort of deteriorates faster than the muscle strength. So the orbicularis kind of overwhelms the perioral skin. So this is why you develop these kind of lines around the perioral area. The temporal area, so this picture basically depicts the hollowing in the temporal region with age. This is also an area which is frequently addressed. So this is a overall basic kind of overview of what happens in each decade. But what I'd like to emphasize is number one, that the aging starts around the third decade, contrary to the belief that mid 40s is when you need to get treated. Early 30s is sort of the right time to start treatments, because the lines start to appear on the forehead, fine lines and the crow's feet start emerging around the eyes, and tear troughs become more prominent at this age. This is why we get many patients, especially women around the mid 30s, who are concerned with respect to this. As you go into the 40s, the nasolabial folds start to deepen. This is one of the main concerns of people in the 40s. And by 50s, the jawline is what is affected mostly. So other than the jawline, most of the wrinkles which already have developed, they sort of go from a dynamic to a static stage. And in the 60s, it's mainly the facial descent. So when we evaluate the face, we look at the shape, that is with respect to the cheeks, how high the cheekbones are, how the chin is, how prominent it is, the length of the forehead, the shape of the eyebrow and the height of the eyebrow, the lid height and the inter-eye distance or the intercanthal distance, the shape of the nose, the lips, the length of the lips, the height of the lips, the cupid's bow, the skin clarity and the texture. So these are basically the superficial and the deep fat compartments which are shown here. Now, various ligaments separate these fat compartments, which make them sort of follow a basic area which they stick to. The deep fat compartment is what is important to us as well. That is the retroorbicularis fat, and that is what is usually augmented with fillers. The various muscles of the face, what we need to most importantly keep in mind with respect to for us as oculofacial surgeons is the location of the corrugator, the procerus here, the corrugator here, the frontalis, the orbicularis oculi, especially the temporal portion, and also the inferior in the lower eyelid for the orbicularis roll that a patient may have. How do we classify wrinkles? It's basically the same thing that I mentioned, the static wrinkles and the dynamic wrinkles. So in your 30s is when the dynamic wrinkles start developing, that is with expression, and by the time you're 60, it's mainly the static wrinkles. So these are the areas which are most commonly addressed. So the lines which develop because of the frontalis, procerus and corrugator, the superior sulcus which hollows, that is the superomedial area, and the tear trough which becomes very prominent. The crow's feet as well, the nasolabial fold. Other areas which we don't usually address is the nasal dorsum. So of late, oculofacial plastic surgeons have sort of been going into facial aesthetics as well. So whenever you're doing a non-surgical nose job, that is when you address these areas. So in order to balance the facial profile, addressing the nose and the tip along with the chin is extremely important. Some of the vessels which we need to keep in mind, the superficial temporal vessels, the supraorbital nerve and the supratrochlear nerve, the nerve bundles, the dorsal nasal artery, the angular artery, the infraorbital vessels. So these are the areas which we commonly need to avoid when we are injecting fillers. With respect to the nerves, the most important would be the facial nerves. So any injection of botulinum toxin which goes too close to any of these areas can affect the motor function of the branches of the facial nerve. Something which is often ignored with respect to filler injections especially is the lymphatic and the flow of lymphatic. So if you can see here, the lymphatics flow in this direction. Now when we inject filler in this area below the eyelid, the fillers tend to sort of accumulate here, especially in patients who get fillers multiple times. They get layered fillers, and they may even get fillers of different G prime and different brands. So whenever the filler is repeated before the other filler has sort of worn out, it causes a risk of lymphatic stasis. So this has to be kept in mind before injecting fillers multiple times for the same patient. The other thing is the difference in between male and female aging, and also the overall anatomy of the male and the female face. This is also important because facial feminization surgery is a big part of facial aesthetics today, although it is an up and coming field. So what's important to keep in mind is that males have a very prominent brow and females have a less prominent brow with respect to oculofacial surgery. So what do we do when we do facial feminization? That is, we cut down the brow. The brow is sort of drilled down and made much less prominent to look like a female brow. Some of the areas which we need to be careful about. One is the glabella region. So here we have the angular artery vein, the dorsal vein here. So it's important that when we perform injections in this area, the injection should be performed superficially. However, when we are in this area, that is the tear trough region, they should be performed deeper. This temporal area which becomes hollow with age, this is another danger zone because of the temporal artery which is here, which is commonly biopsied in giant cell arteritis, etc. So this area is a big danger zone, and it's better to sort of use a cannula in areas where you are concerned about vasculature being compromised. So we stay deep in this area and avoid intravascular injections along this area as well, the lateral zygomatic arch, and near the infraorbital foramen, that is the tear trough, where we mainly inject our fillers. The younger patients we inject low viscosity fillers, and the older patients we inject high viscosity fillers. We need to be careful when we inject low viscosity fillers, as they tend to migrate more easily. Now, these are the sort of codes, the MDS codes, which are given by Allergan. I have no financial interest, but these are the codes with which we sort of plan treatment. So, Allergan has sort of given out certain combinations of injections for various conditions, and this should be followed well. But more importantly, it also gives you the danger zones. So as you can see here, right next to the infraorbital foramen, you can see this is one of the main danger zones when you're doing the cheek area. So for example, CK denotes the cheek, but CK1 is the zygomatic arch, that is here. CK2 is the zygomatic eminence, that is the cheekbone, and so on and so forth. Now, some of the issues which you can have if you inject in the wrong area. One would be tissue necrosis because of decreased perfusion. So, in this, immediately the patient would have blanching in that area and pain. So, you stop injecting immediately, massage the area, and immediately put in a hyaluronidase. Blindness would probably be the last and final issue, but it's very difficult to cause this condition, especially if you avoid the danger areas. So I hope you got an overview of facial anatomy with respect to aesthetics, and I thank you for listening, and whoever is watching the recorded version, thank you for watching. Thank you.
It's an excellent presentation. Thank you, Dr.